All right, guys, we're back in. We're part 3 of this lecture. We're talking about parenteral medications. And what does that mean exactly? That means that we're going through the skin, basically. Usually requires a liquid medication that be drawn up, stored, or injected. And it requires some sort of hypodermic needle. Again, the hollow metal tube that is allowed, it'll let you present that. Oh, excuse me. Let's try that there. And again, this is, of course, the syringe. Everybody has hopefully seen this by this point in our EMS career. So again, how are they packaged? And this is the one I want to make sure that you guys understand. You got a glass ampule. You got single or multi-dose vials. Medicines that aren't actually, they're in a powder. You have to actually mix these guys with a fluid in order to put the medicine into a usable state. Nebulizer vials, again, pre-filled syringes, and intravenous medication fluids. That would be your normal saline lactated ringers, usually in a bigger bag. The ampule is a breakable glass vessel. Again, these are really small, and to obtain the medicine. We're going to do this a lot in lab, but you make sure that we don't have fluid in this little area right here. What we usually do is flick the top part, get all the fluid down to the bottom, in which case we break that top off, usually with a piece of gauze, or they have little plastic things that you can go over and snap the neck of that vial. And once you snap that, by the way, when you draw this up, you really need to draw this up using a filtered needle, because there can be micro glass shards that you can do that. So you want to use a filter needle or a filter, some sort of cannula, but it needs to have that filter on it to make sure that we don't get no glass there. Now, the cool thing about this, guys, is we can hang it upside down and still draw medicine out of it. And the medicine actually won't come out until we begin to pull back on the syringe and then pull it out. So again, we just talked about all that. Again, the medication, and I'm more about practicing this in the lab. And so I really do, guys, want you, we have plenty of practice materials in which to do that. Now, a vial is usually a plastic or a glass container with a self-sealing rubber stopper. So how do we do that? Again, we usually pull back on make sure that we have air in the syringe, and at which point we're going to pop the cap off of the medicine. We're going to, again, clean that rubber stopper. Once we clean it, we're going to inject the air into the vial and then draw back out the medicine that we need. Okay. Make sure, again, check your materials. Again, clean the rubber. Now, sometimes people will not clean it once you just initially pop the cap. I think it's good practice to, once you pop, even if you do pop the seal, to go ahead and clean it with the alcohol prep. Again, non-constituted. What they do is they keep the powder and the fluid separate, and what it does is allows for a longer shelf life. This would be an example. This is a Soluble. Up in here, we have, again, all the fluid. Down here is a powder. And if we mix these together, the shelf life is not near as long. But if we take this, and what we would do in this case is we actually push this down. It pushed that little rubber stopper down, and it allows these to mix. Now, once you get it down there, you need to, again, swirl it around, shake it so that it actually mixes completely. You don't want to have little powder fragments in there, okay? And then at that point, you're going to remove the protective covering. You will expose the rubber stopper at the top. And again, at that point, eject your air, and then draw out whatever that it is that you need for the medicine. This rubber stopper usually doesn't stop the fluid from coming down into the bottom part of this. Again, expel any air once you get to this point. Every now and then, when you will draw up some air, flip it back over, tap it a couple times, and then simply push that air out. We don't want to give air into any line, okay? And then, of course, make sure that you put your needle in the proper place. So again, let's see here. The packaging. Hold on just a second here. Pre-filled or preloaded syringes, and that's what a lot of our medicines actually come into. Make sure once you're in the lab that you know how to screw one of these together or assemble them, okay? And some medication solutions are packaged in an IV bag, and a good example of that would be like a dopamine drip. Usually they come pre-mixed. So again, the parenteral routes, they absorb either locally or they absorb systematically. And that's kind of the really important point to make about that. Now, the good news is we're going to wait right here. This is actually, again, a pretty short video. Actually, no, we're going to keep going. We're just going to keep going. How about that? We'll shorten down the videos here. So the parenteral routes, again, is how we get it into the body. So intradermal, subcutaneous, intermuscular, or IV access. The thing about IV or IO, anything that I can give IV, I can give IO, okay? Especially in the emergency setting, all right? Again, the intradermal route, we want the needle just up underneath the skin. And the way that we do that is, again, we assemble our equipment, and it's usually using a very small needle. If you guys, about the only thing that I know of that we use this for is kind of your TB testing. But yeah, and again, we usually use a really small needle for this particular event. Again, check the medication. Again, draw up whatever it is that you need. Prepare, again, clean the site, concentric circles, just like we do for an IV start. Pull the skin taut, and then you're going to keep the bevel of the needle at the angle of about 10 to 15 degrees, okay? Just up underneath the skin. You're really wanting to put it into the dermis region of the skin, just underneath the dead layer, okay? And then, again, cover the needle of the puncture site using an adhesive bandage. Band-Aid works really good. And then monitor the patient. Anytime we give a medicine to any patient, we should probably monitor them for 15 to 20 minutes, okay? And probably more towards the 20-minute mark. This is where we want the needle. And notice they've got the bevel down. Usually it's bevel up when we give this. I don't know why that's down. But again, insert there, and then cover, then again, 10 to 15 degrees. You just want to get it into that dermal layer, okay? The subcutaneous, now this is actually going into the subcutaneous tissue. So if we back up to this slide here, the subcutaneous, we actually want to get down into this layer of where the blood vessels are. And the reason is that it's going to cause a very slow absorption rate into that area. By the way, this is going into this area very, 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 very slow. Usually it's like I said, a TB test is the only thing I know that we use it for. But your subcutaneous, again, same procedure like we just did the intradermal. The only difference is we're going to go in at about a 45-degree angle on this guy, okay? And we want to do it where we got nice fatty areas. So great places, the back of the arms, the stomach region, if you pinch it up. And by the way, we're going to pinch these areas usually when we're giving a subcutaneous injection. Okay, we pinch it up, get us a nice area of a target fat cells, and then again, after we give the injection, one thing also once you push the needle in, guys, is you want to pull back to make sure that you didn't accidentally hit an arterial or an artery or vein or venule. Again, if you're getting blood back through it, you're going to have to restart at that point. Now, you're again, make sure that you pinch the skin up. That's again, and you want it into the subcutaneous level. This method takes about 15 to 20 minutes to absorb, and that's the key thing I want you to remember when we start talking about the next route, which is intermuscular. So intermuscular goes into the muscle tissue. Again, the places that we usually use is the top of the legs, in the muscular areas, in the gluteus, the butt. Again, into the muscle area, and then we can also use the deltoids. 2 milliliters of fluids into the deltoids should be, you can do 3, but I wouldn't recommend it. 2 milliliters is all you probably want to put in the deltoids. Anything else up to 5 milliliters you can do in the bigger muscles, especially in the butt muscles, you can do 5. But again, you want to keep that, truth be known, you want to keep everything underneath 3 if at all possible. One last thing is your intermuscular injection, guys, they need to go into the muscle tissue at a 90-degree angle. Think of it like throwing a dart, okay? You want it to go straight into the muscle, and then you want to do it with a quick action. So once you do that, again, insert, pull back, make sure that you're not in something that you're not supposed to be, and then at which point you're into the muscle layer, again, 90-degree angle. Now, the medicines that use this absorb approximately 5 to 10 minute, and it depends on really which book you read. Some of them say 5 to 20. It's usually about a 5 to 10 minute absorption once you put it in the muscle. So if you've got a patient that you really want to get the medicine in pretty quick, you really do need to, and a good example of that is Benadryl and epinephrine for if you're having an allergic reaction. Again, a younger patient that we really want to get the epinephrine working on that, IM is the way I'd give it. If it's an older person that I want to slow down the absorption so we don't have as bad as side effects, I would use the subcutaneous route there. By the way, remember that if you're in a shock state, that it draws blood away from the skin. So again, it's going to be faster to get it into the muscle. Okay. Again, draw it up, draw your medicine up. Again, 90-degree angle. Notice how it's straight in, kind of like a dart. As a matter of fact, I think this is kind of low for the deltoid. The deltoid should probably be up here a little bit farther. And continue to monitor the patient. IV starts. Now, the good news is we have already done IV starts, but we're also going to talk about some of the other things with the IV starts. But we're going to do that on our next video, guys, so I'll see you then.